Hello guys, welcome back to VAISHNAVI'S Academy. Today I've come with the topic heart failure, which is from CVS Medicine, and I have referred Davison textbook. Since we all know it's a very important topic related to our professional exams, so let's start with heart failure. First and basic question for us is, what is heart failure? Okay, so it is a clinical syndrome that develops when the heart cannot maintain an adequate output, like it is not able to function properly, so it's not able to maintain an adequate output, or it can do so only at an expense of elevated ventricular filling. Okay, now there are like there are three types of heart failures which we'll learn. First is, we all know the basic of heart: left ventricular, right ventricular, left ventricle, right ventricle, left atrium, right atrium. Okay, so if the left sided heart is failed, then we call it as left heart failure. If right sided heart is failed, then we call right heart failure. And if both the ventriculars are failed to perform properly, then we call it as biventricular failure. So first, what is left heart failure? It is reduction in left ventricular output and raise in left atrial and pulmonary venous pressure. So in the same way, we'll call the right heart failure, that is reduction in right ventricular output and raise in right atrial and systemic venous pressure. There we have pulmonary venous pressure, here we have systemic venous pressure. Cool. Now in left heart failure, if it is such as an MI, we can see that left heart failure occurs suddenly. Why? Because of rapid increase in left atrial pressure, which leads to pulmonary edema. Okay, whereas in mitral stenosis, this rise in atrial pressure which is gradual. In myocardial infarction, the pressure is sudden, but whereas in mitral stenosis, the pressure is gradual. Okay, so it will lead to reflex pulmonary vasoconstriction. Okay, now in right heart failure, such as most common cause is chronic lung disease or pulmonary embolism and pulmonary valvular stenosis. Cool. Now next we go for biventricular heart failure. What do we understand by biventricular heart failure? It is a dilated cardiomyopathy or coronary heart disease which affects both the ventriculars together. Okay, because of disease of, or it might also be because of disease of left heart, eventually the right heart is affected and then both the ventriculars are affected. See, because of disease of left heart, that leads to chronic elevation of left atrial pressure, which causes pulmonary hypertension and causes right heart failure. So left heart failure, we have left atrial pressure increase, pulmonary hypertension and right heart failure. Cool. Now let us understand what is the pathogenesis of heart failure. Here, heart failure occurs when the cardiac output falls, okay, or it fails to meet the demands of circulation. So in circulation, I'll tell you three terminologies, that is preload, afterload and myocardial contractility. What is preload? Preload is the volume and pressure of blood in ventricles at the end of diastole. It is pressure at the end of diastole. Okay, whereas afterload is volume and pressure of blood in ventricles during diastole, at the end of diastole, during diastole. Then we know myocardial contractility. Any of this is affected, we have heart failure. Now what is Starling's law? What do we understand by Starling's law? It is ventricular performance is related to degree of myocardial stretching. Cool. Okay, now what is myocardial dysfunction? Sorry, what is ventricular dysfunction? Ventricles are not able to perform properly. It is the most common cause of heart failure. Okay, here we have impaired systolic contraction due to myocardial disease, or diastolic dysfunction where there is abnormal ventricular relaxation due to stiff non-compliant ventricle. Either the uh, ventricles are not able to contract properly, or there is relaxation of abnormal relaxation of ventricles, or they are non-compliant ventricles. most commonly found in patients of left ventricular hypertrophy. Cool. Now, what is ventricular dysfunction lead to? Ventricular dysfunction leads to decrease in cardiac output. If cardiac output is decreased, our two systems are activated, nervous system and hormonal system. In nervous system we have SNS, sympathetic nervous system, and in hormonal we have RAS, renin, angiotensin, aldosterone system. So if the patient was normal and heart was functioning normal and the heart rate is like cardiac output was decreased, then it would have actually supported the cardiac function if these systems get activated. But since we have a cardiac we have a cardiac myopathy or condition, this leads to impaired ventricular functioning. See, due to impaired ventricular functioning, there's negative consequences. What are the negative consequences? There's increase in both preload and afterload. I've already told you preload and afterload. What is preload? Preload is increased in ventricular and atrial pressure at the end of diastole, whereas afterload is during the systole. Okay. So increase in both preload and afterload is happening due to impaired ventricular function. This leads to a vicious cycle, that is again the fall in cardiac output. And then if this again cardiac output falls, again our SNS and RAS are activated, and this leads to increased peripheral vascular resistance. Okay, now we have a, I'll explain this with a cycle. Okay, it is called neurohormonal cycle. In this, generally what we have first, the thing we have is heart failure. What happens in heart failure? There is reduced cardiac output. Okay, if there is reduced cardiac output, what did I say, what activation happens? Neurohormonal activation. In this neurohormonal activation, I have SNS, I have RAS, I have vasopressin system, and I have endothelial system. So this RAS will actually do sodium water retention, whereas SNS will do vasoconstriction. So sodium water retention will do what? It will increase intravascular volume. Since water is increasing, intravascular volume is increasing, and if vasoconstriction is happening, it will increase the afterload, and these both will eventually go and do what? Increase the BP and cardiac work. We already know that already our heart is failing. Since there's increased BP and increased cardiac work, what it will do? Myocyte loss, which will lead to myocardial fibrosis. Hence, this is again a vicious cycle. Okay, now what the same thing is explained. Prolonged sympathetic stimulation. Sympathetic nervous system is stimulated for a prolonged period of time. It will have negative effects, that is cardiac myocyte apoptosis, death of cardiac cells. Then we have cardiac hypertrophy, increase in number of cells in heart, or focal myocardial necrosis. There is a necrosis in myocardial cells. Vasoconstriction and predisposes to arrhythmias. Okay. Now we have pulmonary and peripheral edema that occurs due to high left and right atrial pressure. What will happen? Pulmonary and peripheral edema due to high left and right atrial pressures, and are compounded by sodium water retention caused by impairment of renal perfusion and secondary hyperaldosteronism. Cool. Now we have high output failure. There we had ventricular failure. Here we have high output failure or valvular disease. In high output failure, generally if there is an AV shunt, if the AV shunt is placed but it is a large, then suddenly there is a high output and it will lead to cardiac failure. Or there might be other cases where there is high output, such as excessively high cardiac output due to very severe anemia or thyrotoxicosis. Okay, and when do we have valvular diseases? Valvular diseases, how many valves do we have? We have tricuspid, mitral, pulmonary, aortic. Okay, any of these valves go into either mitral stenosis or mitral regurgitation, like stenosis or regurgitation, will lead to a valvular diseases. So it is either impaired filling of ventricles due to mitral and tricuspid stenosis, see, impaired filling due to stenosis, or we have obstruction of ventricular outflow due to aortic or pulmonary stenosis, and hypertrophic cardiac myopathy or ventricular overload secondary to valvular regurgitation. Okay. Now, clinical assessment. How do we assess the patient who has come to us and confirm that this person may be having heart failure? There are three types. First is acute heart failure, chronic heart failure, and the other one is acute on chronic heart failure. So, if a person is having acute heart failure, how do we get to know? This sudden onset of dyspnea at rest, and this dyspnea can lead to the rapidly progress to acute respiratory distress, orthopnea, and further it will lead to respiratory failure. Okay, or the patient may appear agitated, pale, clammy. There are cool peripheries. Then we have rapid pulse. But in some cases there might be bradycardia. Mostly it is rapid pulses, but in some cases there might be bradycardia, and the BP is usually high. But in some cases it might be normal or low, such as in cardiogenic shock. Okay. Then we have JVP. JVP is elevated. Okay, and apex not displaced. Gallop. Gallop is rhythm with a third heart sound, so it is heard quite clearly in early stages of development of left sided heart failure. Okay, then new systolic murmur can be heard in acute mitral regurgitation or ventricular septal rupture. Chest examination. In chest examination, we might have three of the findings for related to respiratory things. That is crepitations, which is at the lung base. If it is at the lung base, it is called pulmonary edema. But if the crepitations are throughout the lungs, it is severe case. And if there might be expiratory wheeze. Okay. Then in chronic heart failure, this is how we understand a person is having acute heart failure. Now, what do we see in chronic heart failure? There is relapsing and remittent course, periods of stability and episodes of decompensation. The person might have fatigue, poor effort tolerance, peripheries are cold, low BP, and weakness. These all are the signs of low cardiac output. What are the signs of low cardiac output? Fatigue, poor effort tolerance, peripheries are cold, low BP, and weakness. And if the person is coming with weakness and fatigue, then we have to say that the blood flow is diverted from skeletal muscles, and this causes weakness and fatigue. If the person is having oliguria and uremia, then we have poor renal perfusion. If the person is coming with dyspnea, inspiratory crepitations over the lung bases. I said lung bases crepitations are because of pulmonary edema. So here, if there are dyspnea, inspiratory crepitations over lung bases, then we have pulmonary edema due to left heart failure. If the JVP is high, we have hepatic congestion, dependent peripheral edema, and ascites pleural effusion, we have right heart failure. If there is pulmonary edema, we have dyspnea and crepitations. But if there is peripheral edema, hepatic congestion, ascites, we have right heart failure. Okay. Then other findings are marked weight loss, such as cardiac ataxia, or we have anorexia, which will also lead to weight loss. We have impaired absorption due to GI congestion, poor tissue perfusion due to low cardiac output, or skeletal muscles atrophy due to immobility. These are all the signs of chronic heart failure. Okay. Now, I said another one thing was acute on chronic heart failure. Here, the person is presenting us with acute heart failure symptoms, but we can also see that he has chronic heart failure symptoms. So this is just an acute exacerbation of a chronic heart failure disease. Okay. So acute heart failure sometimes supervenes as a result of decompensating episode on a background chronic heart failure patient. They have both symptoms of acute and chronic heart failure. Now, what are the complications of heart failure? We might have renal failure, hypokalemia, hyperkalemia, hyponatremia, impaired liver function, thromboembolism, atrial and ventricular arrhythmias, sudden death. Okay. So about these complications, since you know what these are, you can just read it and understand what it is. Okay. Now, after this, we have investigations that we need to be done in a person coming with signs of heart failure. So, clinical features of heart failure. So we have chest X-ray, echocardiography, serum urea, creatinine, electrolytes, HB, thyroid function, and BNP. These will all give us confirmation of presence of heart failure. Now, about the management of heart failure, I'll tell you in the part